Hello, and welcome to New Advances in Home Phototherapy for Psoriasis. I'm Stephanie Porter, Director of Medical Affairs for the National Psoriasis Foundation. Thank you for joining us for this accredited continuing education activity. The faculty for this program are well-known researchers and dermatologists who have made significant contributions to the treatment of psoriatic disease. Both are actively involved with the National Psoriasis Foundation and have provided leadership with both research and education initiatives. To find out more about the National Psoriasis Foundation, visit us at our website, psoriasis.org, or on one of our social media platforms. Now, I will hand things over to Dr. Gelfand.
Thank you for being with us today in this educational activity CME program on home phototherapy for psoriasis. There's been a lot of new advances in this area, and I'm really delighted to be here with my close friend and colleague, Dr. Kristina Callis-Duffin from the University of Utah. Kristina and I recently completed a major clinical trial funded by the Patient-Centered Outcomes Research Institute, or PCORI, looking at the effectiveness of home versus office phototherapy for treatment of psoriasis. And what I'm going to do in the next sort of 10 to 15 minutes or so is give you an encore presentation of the data we presented at the American Academy of Dermatology's late-breaking research symposium on March 9th, 2024. As a matter of disclosure, I do a fair amount of consulting and get grants from industry. These are really not related to the presentation today. I want to note that this study was investigator-initiated. Christine and I have been working on this project for quite some time, applied for the grant, got funded by PCORI, and then Davlin provided the home phototherapy for the machines in the study and provide shipping for the devices. The study was designed, executed, analyzed, and reported by the academic authors. All right, so let's just do a level setting here. So we all know in this audience, psoriasis is a very common disease, and we have a lot of new therapeutic options for managing it, whether it be topical, oral medications, or injectable biologics. And I think what we'll show in this presentation is that home phototherapy and office phototherapy, for that matter, remain very important parts of our therapeutic armamentarium, despite the advances that we're seeing in our field. One key aspect of this to keep in mind is that pharmaceutical costs for managing psoriasis are increasing exponentially. In 2023, we spent about $27 billion on pharmaceutical management of psoriasis, and it's estimated that these costs will exceed $50 billion in the US by 2030. And in the context of this, recent publications suggest that phototherapy is about 10 to 100 times less expensive than biologics. In a clinical trial that Kristina and I did, we found that adalimumab actually works about as well as phototherapy, or I should say phototherapy in the office works as well as adalimumab, and actually tends to achieve better responses on patient-reported outcomes. In another head-to-head study that was done by Novartis of office phototherapy versus secukinumab for new onset psoriasis, although secukinumab clearly had better efficacy in that study, there were fewer adverse events and no risk of infection associated with phototherapy. And phototherapy actually achieved quite good responses in that study as well. And as a result, it remains a desirable first option for treating psoriasis by both providers and patients. And the reason why we did the LITE study is that we did a lot of engagement with providers and patients with psoriasis across the United States. And what we learned from this survey work is that phototherapy does remain a preferred treatment option for patients, especially at home when it comes to patients' preferences. But that inconvenience of office phototherapy and copays are major barriers to accessing office phototherapy in the current climate. On top of this, the majority of U.S. counties do not have a dermatologist that offers office phototherapy. And unfortunately, there's been a lack of U.S. data looking at home phototherapy in a diverse U.S. patient population. And that has resulted in some degree of uncertainty for providers in prescribing it, which we're going to try and fix in the CME program today, as well as some variation in insurance companies covering it. And if you've tried to prescribe this, you may notice that, say, Medicare, for example, covers home phototherapy fairly well, but it's very variable amongst different insurers out there. Some insurers, like Kaiser, for example, make it readily available to patients. So it really depends on your setting. And LITE is ultimately a patient-centered study. All the work that we did in the study was informed by patients from the very beginning, as well as patients with the disease who've had phototherapy, payers out there, and dermatology experts as well. This is the way the study was designed. We intended to enroll about 1,050 patients with the goal of proving that home phototherapy works about as well as office phototherapy. The scientific term we use is called non-inferior. Patients were randomized in a one-to-one manner. Uh, all the data was collected during routine patient visits, or from the home phototherapy machine itself, or from a patient's cell phone, the patient's cell phone app that they would use to give us survey data. We ended up enrolling 350 patients with skin type 1, 2, 350 in skin types 3, 4, and 83 in skin types 5, 6. Our goal was to have 350 patients in each skin type group so we could prove non-inferiority based on our power analysis uh, within these different subgroups. And you can imagine a situation where someone who's very fair-skinned, maybe you'd be worried they would burn more in home treatment because the machine may not be as well calibrated as we do in the office, for example. Or maybe someone who's very darkly complected, maybe the treatment times at home will take a long time because the machines have fewer bulbs than what we use in the office, and maybe the treatment won't be as effective for that reason. So that's why we designed the study in this manner. The entry criteria are quite pragmatic and designed to reflect how we actually practice clinical medicine. So patients with 12 or older, they had plaque or guttate psoriasis, and the clinician felt they were a candidate for treatment of phototherapy at the home or the office, and the patient agreed and was willing to be randomized and accept treatment in either arm. These are routine patients being recruited during routine patient care visits, and there were no washouts for any other therapies for psoriasis except phototherapy itself. If someone was currently on phototherapy, they had to be off it for 14 days prior to getting randomized. Now, the in-office arm was basically office phototherapy given by standard of care. We recommended people use the AAD phototherapy guidelines of care that we wrote several years back, but sites could do patients' treatment as they do in their local communities, which is consistent with pragmatic research reflecting people's standard of care. Patients may have had to pay copays or things of that nature, as would happen in the office. If they're randomized to home, they received a commercially available 8-bulb narrowband UVB unit from Davlin. This has a guided mode controller, which allows the patient to determine the escalation of the dose. Essentially, what happens is when the patient has a treatment, just like in the office, they have to fill out a survey question on a keypad to ask, did you have any burning or erythema? How long did it last? And the machine knows what dose to give the patient based on their prior response to the last treatment, as well as when their last dose was. So the machine is using actually the protocol we would recommend from the AAD guidelines. So these are the results of the study. That is sort of the baseline characteristics of what we found. 783 patients enrolled. They were on average middle age, a roughly equal representation of men and women, a very diverse patient population. 25% were non-white, and on average, people tend to be obese. It's very typical for the psoriasis population. Objectively, people had pretty severe disease. The average body surface area was about 12%. The global severity was about 3, which is moderate disease. The average DLQI was about 12, which is as bad as you'll see in any clinical trial of diseases like psoriasis or hidradenitis or other severe diseases. So this reminds us when people show up for dermatology practice and their disease is bad enough that they require phototherapy, they're usually pretty badly impacted by their disease. Also, talking about what I mentioned earlier, the relevance of phototherapy in the modern era here. 40% of people previously tried and failed systemic medications or biologics for psoriasis, and 12% of patients were currently taking these medications at the time of treatment. And this is a reminder that even though we have these amazing therapies for psoriasis, not all patients respond well, or many patients lose response over time, and therefore need adjunctive therapy to help clear their skin when everything else is going well. I mentioned earlier that we did the enrollment and randomization stratified by the skin type. These are the primary results of the study. And what we really showed definitively is that based on being clear, almost clear on a PGA, or having a DLQI score less than 5, which means mild to no impairment in health-related quality of life, that office phototherapy patients did just as well as those treated at home. And this is true across all skin types. And the p-value for non-inferiority was quite extreme. So this really definitively proves the theory or a hypothesis that people could do just as well on home phototherapy, I should say, as they do in the office, whether they have very fair skin or medium complected skin or darkly pigmented skin. And to some extent, even though we had a lower sample size in skin type 5, 6, there the effects were so significant in terms of the difference between the two treatment arms that we were able to prove non-inferiority in that group as well. And overall, the response rates are quite good. You're looking at almost clear rates of roughly 30%, and minimal impact on health-related quality of life of roughly 40 to 60% of patients. The other thing is that people who got home phototherapy are much more likely to be adherent to treatment. On average, they had more treatments at home, and roughly half of them received the ideal number of treatments, at least 2 treatments a week, compared to just 16% of people trying to do phototherapy in the office. And so it's a strong reminder of how patient-centered home phototherapy is. They could do it on nights, on weekends when it's convenient for them, as opposed to trying to get into our offices during our regular office hours. Now, given that patients at home were getting more treatments, not surprisingly, they had more treatments that were associated with persistent erythema. Roughly 5% of treatments done at home had persistent erythema 48 hours or more, according to the patient's report, compared to just about 1% in the office setting. But when we asked patients about this, most of them felt like this persistent erythema had no symptoms or only little symptoms in their skin. So it wasn't really clinically significant for the patients. And we actually had no patients stop phototherapy at home or the office in this clinical study due to concerns about persistent erythema. So that's encouraging for our patients. The other thing is, I mentioned earlier that people at home were more adherent to treatment. We then looked at effectiveness amongst people who were adherent, meaning they had at least 2 treatments a week during the course of the study. And what we find is that overall, patients do really well when they're adherent to phototherapy. About 60% achieve clear, almost clear skin. Roughly 50% achieve what's the equivalent of a 90% PASI, PASI 90 response, which we often use in clinical trials. And you see when there's better adherence, we still have non-inferiority between home and office, but the difference between the response rates becomes less, which is what you would expect. The home machines are giving the same dose of light, same treatment. There really is no reason why there should be a difference in effectiveness, except for issues related to adherence. So some conclusions here. Home phototherapy, clearly non-inferior to office phototherapy across all skin types, and for both of our primary outcomes, being clear, almost clear, and having no to minimal impact on health-related quality of life. And remarkably, both home and office phototherapy have excellent effectiveness and safety in real-world settings. We could try these treatments in patients who are often very difficult to treat, as we showed in this population. These were heavily pretreated with biologics and oral medications, for example, and patients still do very, very well. This data, based on the size and scope of the study at 42 centers across the United States, supports use of home phototherapy as a first-line treatment option for people with psoriasis, including those who had no prior phototherapy. I didn't show you that data point in this talk, but we looked at the data and found that if you had no history of phototherapy, you did just as well as if you had a prior history of phototherapy. So it's not like we're only selecting people here who we know do well on phototherapy. People who are new to phototherapy do just as well as those who are previously experienced. And that's really important teaching point, because some patients may not have the ability to come to the office for a trial of phototherapy. And finally, clearly, we need to make efforts to make home and office phototherapy more available to patients. We know from other data that we've collected that there's just big barriers, geographic barriers to coming to the office, financial barriers in terms of co-pays to patients, obviously barriers to home phototherapy in terms of the difficulty of getting it approved by insurance companies. And this is something that Kristina and I are working very closely with National Psoriasis Foundation to help move our field forward and make these effective therapies more available to clinicians and patients who need them. I'll just end there by saying that clinical research is the ultimate team sport. Christine and I were lucky to be supported by many, many people, a patient committee, a payer committee, experts in the field, and all these incredible colleagues of ours, as well as people from my lab who help run this clinical study. And of course, Picori, we appreciate their efforts for funding the study, Davlin's partnership in it, and of course, the National Psoriasis Foundation, who's been a key stakeholder in all this work. So I'm going to stop there and I'm going to turn it over to Dr. Callis-Duffin.
Thank you so much, Dr. Gelfand. Right. So we're going to turn 90 degrees here now and start talking a little bit more about uh, the very pragmatic aspects of prescribing. Uh, we want to put all the data that Dr. Gelfand just presented into action. And one of the challenges that we have is that providers often feel very uncomfortable doing this. And there's just a few things that have, I think, improved and changed over the last few years, including what changed as a result of the LITE study as we administered home phototherapy. So we're going to go through that. So this is a very pragmatic kind of talk. My industry relationships are not really relevant to this other than Davlin, which is a manufacturer of a home unit, provided our units for the LIGHT study, but I have no financial relationship to Davlin or other manufacturers in otherwise. So as I said, many clinicians say, I would like to prescribe a home narrowband UVB unit, but I've never ordered one, or I haven't done one in years, or I do them very rarely, and I'm uncomfortable. I need help with the process. So what do you need to know to comfortably and safely prescribe a home narrowband unit? So this process might seem a little bit daunting, but actually, if you break it down, the part that the provider really needs to know is how to decide if a patient is right for home phototherapy, how to place the orders just like you would do it in office with some nuance. The manufacturer essentially does the second part. So the second part is the authorization through the payer. They work with the payer, the patient to finish the purchase of the unit. They're communicating with the patient the whole time. The arrival and the setup component can be done entirely between the manufacturer and the patient. And then the treatment initiation, which is the third part, which is a little bit more patient education, can be done by the team, but it can also be done in support by the manufacturer. And so the provider really appropriately working at the top of their license does the decision making, the prescribing, and then the follow up to fine tune the therapy. So, patient selection, similar to the LIGHT study criteria, good candidates are going to be patients who have plaque psoriasis that's not too thick, guttate psoriasis that's exposable, trunk, extremities, sometimes on the face, without contraindications. These patients have to be motivated and able to direct their own dosing. They have to be able to set up the unit, have a place to do it, follow the instructions, the protocol, understand a little more about how to troubleshoot, and then they have to be able to follow up with a provider. And currently, you really have to have insurance benefits that cover the home unit, which is continuing to be a barrier, but we hope to change that in the future. Patient selections, patients that are not great candidates for phototherapy are the same for home phototherapy, right? Distribution and phenotype, scalp, inverse disease, nail disease is predominant phenotypes, very thick scalar in duration because narrowband UVB just does not penetrate through very thick plaques the way that PUVA would do. So if patients have these phenotypes, they might not be great candidates, although you can combine systemic therapies to make phototherapy more effective outside the scope of this talk. And then, of course, where UV is contraindicated in patients that are on photosensitizing medications, have lupus, photosensitizing conditions, skin cancer risk. But the barriers, again, tend to be more pragmatic. Patients who have no insurance, have a safe place or a good place to set it up, or just have challenges following these instructions. So the ordering has been made very simple. Both manufacturers that I'm going to talk about today, Davlin and National Biologic, and others that are out there, have multiple ways of ordering. There are, of course, printable forms, but now there are online forms and portals. A portal where you can put all of your patients in. The practice can manage it, and they can do refills. And all the websites have many resources for education for both providers and patients. So there's quite a lot more educational material out there, and the manufacturers support all this. So in terms of the ordering, there are a few things you have to be able to do. First, you have to decide which unit. So I'm going to keep the scope here to be a 6 foot, full size unit. So those units at their largest have 12 lamps. You can order them with 4, 8, and 12 lamps now across the two manufacturers that I'll talk about today, Davlin and National Biologic. Most insurers will approve an 8 lamp unit. And Kaiser, which actually has this as a step, that they have to fail phototherapy in home before they can move on to some things, will give patients a 4 lamp unit. And then you have to decide on the controller. Now, if a patient wants a smaller unit, like a 1 by 2 foot or 2 by 4 foot, or even a handheld unit, the ordering process is very, very similar. It's just there's less data known about those kinds of units, and you have to be careful about selecting. You don't want to get a small unit and then the patient has generalized psoriasis. The last part is the controller, the interface of how the patient's going to control the time or the dose. And there are a few things to know about that. Which timer or dosimeter guided mode controller you want to use is very dependent on your comfort level and what kind of therapy you want to give your patient, right? How easy do you want to make this for your patient, or how customizable do you want to make it? So we'll go through that. And then the last thing to say is you have to decide about a dose limiter. Um, this is important because you don't want the patient to just run off and never have a dose limit, never follow up with you. So usually we put in 50, 100 treatments so that so it won't turn on after a few months, so they will come back and follow up with you. And also, it's a safety issue. They need a code or turn it on, then children and other people couldn't use it. The number of the lamps matters a lot in terms of efficiency of treatment and timing. So if you order a unit that has 12 bulbs, the output is going to vary, 'cause the irradiance that comes with these is going to vary by the manufacturing. So the manufacturer will tell you what's the output of the unit. So a 12 bulb unit on average is going to be somewhere plus or minus 10 milliwatts per centimeter squared, which is 10 millijoules per second. But a 4 bulb unit is going to be closer to 3 plus or minus, so 3 millijoules per second. So that's a 3 times variance there. And so the amount of time they're going to stand in front of that unit, say they start at 300 millijoules, that's going to be at 30 seconds for somebody who has a 12 bulb unit versus a minute 40 for 4 bulb. And if once they get out to say 1500 millijoules, maybe they're getting close to their maximum dose, that's 2.5 minutes versus almost 8.5 minutes. So this matters to patients, especially if they have darker skin types. They might need to get out to many more minutes. And if they have a 4 bulb unit, that could be standing just for one side of exposure for a very long time. So really, I generally try to opt for the bigger unit if possible. And then this is the other part of the old timers, right? You have to be able to convert time and dose, and that's a little bit tricky. So I'm going to go into that in a second. In terms of protocol ordering, this is the protocol that's published by the Journal of the American Academy of Dermatology in 2019. This is a protocol driven starting dose, which is an estimate for skin types 1 and 2 to start at 300, 3 and 4, 500, and 5 and 6, 800 millijoules. And the definitions there of the different Fitzpatrick skin types. So 300, 500, 800 are the numbers that you need to know. And then the max dosing is approximately 6 times that. And certainly you can do MED testing if you want, but that's, again, outside the scope of this. After the patient starts, of course, you have to do dose increases because of photoadaptation. And most patients will tolerate, because of the science of photoadaptation, about 15 to 20% increase each time. So that's 15 to 20% of the last dose that they got, increasing it for treatments at about 2 to 3 days apart. So every other day, 48 to 72 hours. Usually wait at least 72 hours after the first dose just to make sure they don't have a delayed amount of erythema. And then over time, this will peak and then drop slightly, and it drops fairly quickly after you withdraw narrowband. So there are instructions published for how to do this if there are gaps. So again, going back to the controller, there are these different kinds of controllers, which are, for the most part, time and dose based. So both manufacturers will use either a time or a dose based controller. And the difference here is that if you know what your dose is, then you can convert it into time, and that can make it very easy. For example, if you knew that a patient needed to start at a minute, say for a box that has a 5 milliwatt output, so they start at 1 minute, then you can say, well, what's 15% of that? That's about 9 millijoules. You can say, roughly increase each dose by 10 seconds. So you can make it really easy that way, or you can do it by percentages. You can also have patients get a dosimeter where they're actually entering a dose, and then they have to do a dose increase by the percentage again. The new thing that's out there that Davlin manufactured for the LITE study and is now available is something called guided mode, which is kind of a game changer, I think, for home phototherapy for patients who might not really understand or have trouble with the timer or dose entry. So it's patient control. The patient answers questions to determine their next dose, and I'm going to show that in a minute. And then again, we recommend using the dose limiter. Okay, so this is probably the single most important thing for people to remember when they're trying to figure out starting dose and transitioning dose is if I want to start the patient on a certain dose, how do I convert it to time? Right? So what happens is when they send the patient the paperwork, they'll give the patient the factory output, which is in milliwatts per centimeter squared. So it'll be somewhere between like 2 and 12 milliwatts per centimeter squared. And all that means is milliwatts per centimeter squared is millijoules per second. So if the unit factory output is 5, then it delivers 5 millijoules per second, right? So it's just some simple math to then get to the time. So if you have a 5 milliwatt per centimeter squared and you want to start them at 300, it's just 300 divided by 5, which is 60 seconds. And then the increase, a 15% increase, 9 seconds, 20% increase, 12 seconds, is just adding it to the last dose. So 60 seconds plus 12, 72 seconds. So it's just simple math, which can be kind of tricky. There's a couple ways people do increases. One is fixed dose, one is percentage based. Fixed dose is fine. It's very simple. Say use that last example, 60 seconds, round it to 10 till the patient started a minute, increase by 10 seconds. Problem is that over time, that fixed dose is actually a smaller and smaller percentage of the total dose. So you're slowing down your increase, which I don't prefer. I don't think that's a great way to do it. I prefer the percentage-based increases, but then that involves some more complicated math, as I've shown here. But there are applications. You can download a web application or an app on your phone or your smartphone, which can calculate those things for the patient. Very easy to use. This is on the website. This is on an app. The guided mode basically displays here up in this corner. You can see the display of this of the controller says, were you in pain or red after your last treatment? And the patient would then answer no or less than 24 hours, in which case the device will automatically increase by whatever you told them to program it to. So if you want to increase it by 10%, you can tell them to increase it by 10%. If they were in pain or had redness between 24 and 48 hours after the last treatment, you can tell it to then deliver the same dose. You can decrease if they're still red or sore after 48 hours. And if they're still red and pain at the time they turn it on, it'll lock them out and it'll decrease it by the amount you say. Again, most people will do 2 steps down, right? So if you were doing 20% increases, you might decrease it by 40%.
Can you guys
So
comment
so
on this slide? First of all, it's such a perfect, beautiful presentation, and this is sort of how we did it in the LITE study. In the LITE study, we increased by 20%. That's sort of the protocol we use at Penn, and I think Utah uses what the guidelines say. Um, so you can see if you're a little concerned about them having erythema, okay, well, just say have them increase it by 15%, each time. Or if you're very worried about the patient having erythema, okay, 10%. But the reality is we are trying to get everyone to develop a little bit of erythema that persists for less than 24 hours. That's the sweet dose. And then when the patient answers the buttons, the machine will then know what dose to give them, so they don't end up having a problem with persistent erythema on their skin when they get these treatment doses. And one of the things what was remarkable to me in the LITE studies, we had all these experts around the country, as well as people who don't do a lot of phototherapy, but we had several real experts, and none of us who were the experts, yourself and me, ever deviated from this standard phototherapy protocol. We use the baseline prescription that works with this guide mode dosimetry. And so that's the reassurance for those out there. You don't have to be me or Kristina to use these home machines. The defaults work really well for most patients. And the reality is that none of us, in the roughly 400 people got randomized at home, ever customized it behind the defaults. We just sort of used the run-of-the-mill protocol. But if you're a tinkerer, there's an opportunity to tinker here.
Right. So I think the guided mode is really, really nice for patients because they don't have to think ever again about dose or time. And you don't have to think about it as a provider. You can just give the protocol straight up, which again, if you order one of these, and this is a Davlin specific product, you can order your dosing protocol right online using customized forms. You can reuse it. So this just takes the guesswork out of it. Sometimes patients want to customize more. Maybe they have certain areas of their body where they want to play around with it with dose. That's where a timer or dosimeter might be more useful because you're a little bit locked in here. So it's and again, Davlin supports the use of this if there's troubleshooting to be done, but it really makes it much easier for patients. So, as I said before, the authorization, purchase, arrival, and setup, really the manufacturers will guide the patient through all of this. And so you just refer patients back to this. The last part is just getting them started. And what I've done in my unit is train my phototherapy nurses and staff on how to get them started. It's the same counseling, it's just now they're doing it at home instead of in the office, right? So things like how far away should they stand, mineral oil be applied, what's the starting dose, reviewing that data. I have a handout that I give patients. I tell them to call me when it arrives so I know that they're set to go, that they could call the manufacturer, make sure it's intact. They'll replace the bulbs if they're broken. They'll go over the dosing, and then I make sure that they log their dose and their forms to do that. This is that patient instruction template that Davlin provides online. All of the websites have all great videos. These are the National Biologic videos. These are the Davlin videos that walk patients right through how to use the controller. Their provider videos as well. And then I always encourage the patients to download and print out one of these phototherapy logs, which tells you what the dose is. And the ClearLink guided mode controller actually allows a jump drive to be inserted, and they can bring it to you if you want to see that data in an electronic format. I usually have patients come back kind of early, 6 weeks, but 6 to 12 weeks. We did 12 weeks in the LITE study, so we know that is safe and effective. But I always encourage patients to come in if they're having call if they're having any challenges. And then in terms of troubleshooting, just my last couple of slides, patients will sometimes come in and say, I'm just not getting better. You've got to really drill down on how often are you using it? Are you traveling? Some people get that home exercise equipment syndrome where like, oh yeah, it's there. I just don't want to use it or I forgot. Maybe they don't have a private space. So sometimes there are barriers to using this. You want to try to address these before they get a home unit. Sometimes their dose increasing is not adequate. I've often had patients say, I'm just afraid to go up on the dose. I'm afraid I'm going to get burned. And to Joel's point a second ago, he said, you want patients to get pinked in the first 24 hours. That means that they are going to photo adapt and get efficacy. So sometimes patients will interpret burn as pinkness. And you have to encourage them to get a little bit pink. But if it's hurting, then they've crossed the line into burn. Sometimes they don't understand their follow the protocol. Sometimes patients, you say, "What dose are you on now?" And they're like, "What do you mean? The dose you gave me?" And they just completely miss the message that they need to do the increases. And I think if you do all these steps now, you won't have problems there. I recommend using like mineral oil or Vaseline before starting, standing on a stool if they have lower leg or feet lesions. Um, do they need to add some other topicals or systemic therapy? Sometimes we do that. And then burning, again, if they're burning, are they standing too close? Is it too frequent? Is the dose too high? Do they need to reduce the frequency of the increases? Are they on new meds? And then if they miss time, a week or two or four, there's protocol to decrease the dose. And that's also published into the Dablin orders if you choose to go that direction. These are some ordering resources. They're all on the websites. They're very easy. Our practice uses the ClearLink portal now. So we basically provide orders in Epic, which can then be entered by our staff into the portal where they can manage everything with from refills to new prescriptions, custom protocols, um, and and so that's just a practice decision. Not recommending one or the other. Just think it's a new tool that you could explore. Um, Usually, insurance companies dictate which company you get to use anyway. So that is, I think, the end of my presentation, and I'll say thank you, and I'll stop sharing.
Yeah, that was really great, Christina. Maybe you and I can have just a brief conversation of how we're doing this in practice,
Mhm.
because I thought it was super helpful. And I think one of the benefits of the LITE study is that it was truly real world. These are everyday patients at 42 dermatology sites around the country, many of whom have never used home phototherapy in their own practices, and the patients did very well. So that's sort of reassuring, but it's ultimately the manufacturers of these devices. When we put this prescription in, they are engaged in educating the patient how to use the devices properly as well. And so there's a little bit of a team effort that goes on. Some of the things I've done in my practice, we do use the portal that you recommended there. That's very easy for our staff to do. And I have smart phrases in my medical record. I just press a button and it gives patients information about home phototherapy. Should they cover their face with a pillowcase? Should they cover their trunk, which is only the extremities? Put the emollients on the skin beforehand. Stand 9 inches away from the bulbs. And also we have some issues around saying, well, phototherapy could prematurely age the skin, possibly could increase the skin cancer, the standard consenting we would do if we were going to do this in the office. So it's actually fairly streamlined service once you've sort of figured out how to operationalize it in your own practice. And I'd say to our colleagues who are listening to this out there, it's extremely gratifying to help patients in this way. Because oftentimes these patients are in distress. For some reason, they can't be on a biologic, maybe, or they've been failing biologics, or they're pregnant, and to be able to offer patients the ability to control their own treatment within the parameters, obviously, right? That we set up here, access it when they need it is incredibly confidence boosting for them and rewarding for them. So I really encourage people to listen to your video is amazing and try this in their own practice, because I find it really rewarding in my own practice.
Yeah, thank you, Joel. And I think that kind of going back to your presentation, uh, I think all of those barriers we talked about all the way around, like we were unsure how patients would do with different skin types. We were unsure how a population was going to do at home, and we had to deliver a box and they had to set it up themselves and send
Hmm.
it back, right, in the
Yes.
study. And there's so many things that came out of this that were not just very rigorous data, but also just the pragmatic things like
Yep.
the guided mode and just the fact that we could increase the frequency of the treatments just by delivering home phototherapy.
And we know it even works during a global pandemic.
Yeah.
Because, of course, the study was affected by COVID in 2020. Amazingly, sites shut down for less than 2 weeks before they were back at treating patients. And those who were getting treatment at home were able to continue home phototherapy. A lot of visits were done via telemedicine. So it's pretty remarkably thing you could adapt under a lot of different circumstances.
And the other thing that the pandemic did for us is help us do telehealth. And telehealth is really well set up for delivering home phototherapy because if you want to Okay, you want to be reimbursed for the things that you do. So
Hmm.
you can get onto a telehealth visit if a patient's like, I just need some more help to, how do I stand? You can see the unit with them on the telehealth
That's
screen,
right.
right? Like
Hmm.
you can walk them through that if they need that level of help, which to date I haven't had to do. But if you want to do that 6-week follow-up by telehealth, boy, that's a game changer too, that we weren't able to do that until after the pandemic. So that really helped facilitate it. And now we have more work to do in the payer side.
Yeah.
What do you think the next steps are there, Joel?
Well, I think the data can be very compelling to payers, and the biggest barrier we're facing here, Christina, is that payers are siloed. They have a medical benefit and a durable medical goods benefit. So, medical benefit is you need a statin for your cholesterol, a blood pressure medication, or a biologic. Okay, durable medical goods are like you need crutches. Okay, so you could imagine on the durable medical goods side, they think home phototherapy seems pretty expensive, when in reality, it's orders of magnitude less expensive than the biologics we use for psoriasis. So it's working with payers, helping to understand these nuances and rethinking how they allocate their own internal budgets to try and make a therapy more available to people when it's appropriate for those patients. So I think that's really what this is going to be about.
Yeah, and then taking that data to show them it's safe and efficacious. There's a lot of misperception and dogma out there that, oh, these are not tested, they're not safe, they're not they're not going to work. And the nice thing about that guided mode is that you can't really cause a huge increase, right?
That's
You
right.
can't like accidentally put in 10 times the dose.
White, if really scrutinized, argues that in fact you could get better outcomes at home than in the office. The adherence being the main challenge, right? And so that's why integrated health systems like Kaiser have already made home phototherapy available for their patients. They know that patients often welcome it in their treatment paradigm, and it's a good way to get good outcomes and also bend your health costs in the appropriate setting. I personally believe that this should all be shared decision making between the patient and the clinician. And when biologics are appropriate, by all means, that's the path they should go on. Just like when phototherapy is appropriate, that's the path they should go on as well.